Okay, guys, a very good morning to everyone. Today is the second day of enzyme class biochemistry. Yesterday we have discussed the coenzyme. We stopped at coenzymes. We had an introductory part of enzymes in the part one of this video. Before watching this video, you have to watch the part one. We said coenzymes. They can be nucleotides. They can be nucleotide derivatives. Yes, or they can be vitamins, they can be, lipoic acid. And at the same time, I told you that we have nucleotide derivatives, which are nucleotides and derivatives, but they are not coenzymes. Yes. So SAM, S-adenosyl methionine, is a methyl donor, which is not a coenzyme. Okay. Two exceptions are there. PAPS, phosphoadenosyl phosphosulfate, donating the sulfate, is not a coenzyme but is a nucleotide derivative. And rest NAD, NADP, FMN, FAD, these all are nucleotides which are acting as coenzymes. Yes, uh, and I maybe have given you some exceptions. Maybe I gave you or not. I hope you remember that we had cytochrome C oxidase. Let me write it here. So we had cytochrome C oxidase, and this cytochrome C oxidase uses a cofactor, copper. It uses copper. I would list some examples for you, which is rightly written in your standard textbooks. For example, we have tyrosinase for making melanin. Tyrosinase also uses. So can I say oxidases? See, remember a general concept. Oxidases will use dash copper. Oxidases will use. Do we remember this from the basics I have taught you? Yes. So copper, I will be using oxidases. So if I have cytochrome oxidase, I have tyrosinase, I have lysyl oxidase. Yes, I have ascorbic acid. If I go to vitamin C, ascorbic acid oxidase. Okay. Do you remember I had taught you something called SOD, superoxide dismutase, superoxide dismutase. Do you remember? So this superoxide dismutase can be of two types. Who can tell me? Who can tell us? Let us try. Now everywhere when we start discussing about superoxide dismutase, everyone in the class start jumping, as if it was the last chance to answer, isn't it? Everyone starts making so much noise about this superoxide dismutase, and then when we ask more about it, and maybe we get a pause, isn't it? A speed breaker. So let us contribute, yes, guys. What do you think? The superoxide dismutase. Is there any difference? Is there any type? So yes. Before going to this, I want to say I gave you a statement right now that oxidase is your copper. I said this statement, oxidase is used copper. But there are two exceptions to this. Two enzymes, two oxidases don't use copper. Rather, they use molybdenum. So please remember, this may be asked in an entrance exam, maybe, that which two oxidases are exception. Two oxidases, those are using molybdenum. What are those? Xanthine oxidase and sulfide oxidase, right? And this was what I Forgot to tell you in the beginning. Okay, please remember this. Next concept is that we have superoxide dismutase. We have cytosolic superoxide dismutase. We have mitochondrial superoxide dismutase. Cytosolic superoxide dismutase will use Cu. Okay. So C, how I remember it is C for C. C for C. And mitochondrial SOD. I remember M for manganese. It's manganese. It's not magnesium. It's manganese. I don't remember the spelling, but yes, I will try. Manganese. This is manganese. Are we able to understand how to remember? So what we do is we start cramming things, but cramming is not important. Important is whether we know the difference first. Are we able to understand? Are we able to understand? So if I tell you, even if I have a deficiency of copper, still two pathways can work. That is xanthine oxidase, sulfite oxidase. If I have a deficiency of molybdenum, then definitely only two oxidases are going to, in the context of oxidases, two oxidases are going to be, impaired functioning will happen. Xanthine oxidase and sulfite oxidase. Correct? Are we able to understand, guys? Or we are sleeping? We should sleep, isn't it? We are sleeping, enjoying, isn't it? So, by the way, guys, yesterday I told you that, do you remember that we were discussing something about a therapeutic approach? Yes, yesterday I said a line about a therapeutic approach. Let me first see the chat box. Yes. Yes. Yesterday I gave a line because please listen to my lecture carefully. I speak, I don't know, but I keep on speaking and speaking. Maybe it may give you some points. Okay. I don't write everything. So you can pause the video and write, when you are listening to me. Okay. Yeah, because we don't have so much time that I start writing like a child. You have to understand. I remember, um, how to make you understand. Remember, we have two pro-drugs in the market. Those are nucleoside analogs. They are nucleoside analogs. Okay. So I have taught in my pharmacology basics, there is a concept of pro-drug. There is a concept of pro-drug. What is a pro-drug? Pro-drug just means that I have a drug. I have a molecular structure which is not itself able to work but needs to be activated by my body. I will make it easy. I'm not speaking pharmacology because we are first year. You are teaching the first year people. I have something in my hand. I took it. I ingested it. But when I was taking that, I was that thing is not able to work unless and until it goes to my liver. It goes to my cells which have the potential, which have the capability, which have the capacity to activate that drug, and then it will get converted into an active drug. Then it may have a nice efficacy, a nice potency, all that. What we do is we have something called nucleoside analogs. We have something. Why? Oh my God! Just a second. Okay. Yes. Now see, we have something called nucleoside analogs. Nucleoside, not tide. Nucleoside analogs. Nucleoside analogs include valacyclovir, valacyclovir, valganciclovir, Okay, they are basically, see, I remember them as, since there is val, so val is val and valine. So this is a valine ester. These are valine ester products. They are products, valine ester products. You know, when we see anything written with VIR, it means it is an antiviral drug. Like we have acyclovir, ganciclovir, retinovir, and navir. So these all are going to be antivirals. Antivirals. Okay. So valcyclovir, valganciclovir. These are valine ester products of what? Product of what? Acyclovir. So they are valine ester products of acyclovir. Correct? You know where we are using this acyclovir? Have you seen, you have sometimes some eruptions, blister type of a sort of thing around your angles of the lips, angles of the mouth, no, around the labias, you have some, eruptions, that's a herpes simplex. Okay. So when we are treating HSV1 or HSV2 infections, when we are treating these infections, or varicella zoster, even VZV, chickenpox, varicella zoster infections, and the reinfection I have taught you, the shingles. So when we are treating them, we give a drug, usually this acyclovir. Acyclovir. So the prodrug of this acyclovir is valacyclovir, valganciclovir. And then we have some other drug, that is ganciclovir. So ganciclovir, you know how we know where we are using this for your first year level, I would say. Remember G for giant. G for giant. I remember this as like this, G for giant. A giant means a tall person. So that means CMV, cytomegalovirus, CMV. So we have a condition in ophthalmology, virology, whatever you call, that is cytomegalovirus retinitis. We get a retinitis with cytomegalovirus. For example, I get a patient, he's an AIDS patient, and after doing the ophthalmologic examination, I am able to appreciate that the cytomegalovirus retinitis has happened. Cytomegalovirus retinitis has happened. Correct? So I give them ganciclovir. Are you able to understand or not? Are you able to understand? You are at the first year level, that's why I'm not going so much detail. Okay. Correct. So can you tell me the features of CMV retinitis? Can anyone of you from the third year? We have people from third year. Can you tell me the features of CMV retinitis? Yeah. Okay, guys. So CMV retinitis, we usually get a progressive hemorrhagic type of necrotizing retinitis. So we get a necrotizing retinitis. Okay, let me write. So CMV retinitis. I won't write all the features. I want to explain ophthalmology, but here we are in first year, so that's why I will keep it simple. So we get a progressive hemorrhagic necrotizing retinitis. Okay, and about 15 to 40% of patients who develop, AIDS patients, they will come to you with the CMV retinitis. We have all these retinopathies in AIDS patient, correct? And definitely the CD4 count is gonna be less than 50 cells per mm cube. Okay. And it's not that they will come to you with a unilateral presentation, means one eye presentation. They can come to you with about maybe 50% of the patients of CMV retinitis will be bilateral at presentation. So these are some things you need to study in, pathology and ophthalmology. Okay. So we are using this, we're treating this condition with ganciclovir. So ganciclovir is used for this condition, CMV retinitis, and acyclovir I'm using for treating herpes simplex type 1, 2 and varicella zoster virus infection. So all these two things respectively. What we did, what is the function that I'm going to tell you is my intestinal enzymes, my hepatic enzymes. Listen. When I gave this drug, the prodrug, what is prodrug? Valacyclovir will produce. So valacyclovir for cyclovir, acyclovir, isn't it? Val acyclovir, isn't it? So val ganciclovir for ganciclovir. Are you able to understand? So we have prodrugs. Prodrugs. Are we able to understand? So this drug will give us this compound. Are you able to understand? Is it clear? So what is the concept behind this? Is when I give this prodrug, my body, my hepatic enzymes, the enzymes in the liver, my intestinal enzymes, they convert these prodrug into an active drug. Okay, so can any one of you tell me how to treat shingles? Or if I have outbreaks of HSV type 2 infection, we give FAMC clover. So FAMC we give for shingles. It is basically a acyclovir compound which is used for shingles. And if we have a recurrent outbreaks of herpes simplex type 2. So your intestinal enzymes are gonna be converting these products. So this comes as an enzyme, this can be said to some relation with the enzyme. I thought to give you this drug also so that you can, it helps you, increases your knowledge. Okay, fine. Correct. Now see, there is something called isoenzyme. When you come across the system, there is something called isoenzyme. Let me write isoenzyme. What is isoenzyme? Isoenzyme means, iso means same. It is not that enzyme is same. There is a distinction between the enzymes. There is a distinction between these set of enzymes which are isoenzyme. It does not mean, when I was in my medical school, first year of medicine, when the teacher uttered this thing, I was confused. I opened the book later on, and I came to know the story was different. It was so easy to understand, but we were confused, unfortunately. So what we think is not that thing, but what you infer from the words is not actually the meaning of the thing. You have to understand it correctly and mindfully. Isoenzymes means we have a physical distinction in the forms of enzyme, but they are catalyzing the same biochemical reaction. They are catalyzing the same biochemical reaction. So that biochemical reactions are same, but they are physically distinct. The enzymes are physically distinct. So same reactions, they are catalyzing the same biochemical reaction. Correct. So what are the features that we talk about the isoenzymes? Isoenzymes are going to cause, they are going to catalyze same reaction. So we write it as this reaction, same enzyme, and they are belonging to the same person, the human being. It is belonging to the same person, the human being. So I write species. So these three things you have to remember. So these three things I would say are the features of isoenzyme. Then sir, you said right now that they are physically distinct. Yes, they are physically distinct. They are physically distinct. Why? In the structure. They are distinct in what? If they are same in a same reaction, catalyzing the same reaction, same enzyme, same species, Then what is the difference? The difference lies in the isoenzymes, in their structure. So difference in the isoenzyme structure is they are going to have a monomer difference. There is gonna be a monomer difference. I will give you an example. The famous example and the favorite example of every biochemistry student and teacher, LDH. LDH, lactate dehydrogenase. Guys, you must have come across this. We have how many types we write always? 5. LDH1, LDH2, LDH3, 4, and 5. Yes. Let me write it full, otherwise you will start making it. You are going to make it a hydrogen 5 compound, isn't it? I don't trust the students, so I have to speak everything. Yeah. So what I see in LDH1 is not same as LDH5. What I see in LDH2 is not same as LDH4. What I see in LDH3 is not same as LDH1. So what is the same and different? The same and different is the monomers, the subunits. If you see the structure of LDH1, I will make 1 heart, 2 heart, 3 heart, 4 heart. Correct? So 4 hearts, that means it is present in heart. The location is heart. And the monomers are all the hearts. Let me use a red N because I hope you like this heart. You keep on sending your loved ones this heart, beating heart, dark heart, green heart, yellow heart, so many hearts. So let us also make some heart here. But don't think I'm making heart for you people. Yeah, I'm making it for study purpose. Okay, yeah. So this is some people are enjoying. Okay, so this heart, yeah. So this heart is for heart. Okay, this is for heart. When I see the structure of LDH2, I appreciate that there is 1 heart, 2 heart, 3 heart, and 1 is a muscle. That means the location. First thing I will tell you, it's not that I am giving it on the location basis. It is the structure, the monomer. These are monomers. These are all monomers. So what is the location of LDH2? We have seen it as a plasma enzyme. These are plasma enzymes. That is, they must be in the blood. But mostly you see them, especially in the WBC. Correct. When I talk about LDH3, LDH3 is going to have an equal, I should mark like this. So 2 monomers for heart and 2 monomers for muscle. 2 monomers for muscle. Okay. Then in LDH4, I am able to see only 1 heart and then 3. Are you able to understand what I am doing, guys? Don't think that I am making hearts in the human body. I am making it as a monomer. Okay, yeah. And then when I see the LDH5, I appreciate that I am seeing, no, in the LDH3, I saw equal. And in the LDH4 and 5, they are going to have same. They are going to be present in muscle and liver. But there is one difference. So what is the difference? The difference is muscle, 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 muscle. So I write it as muscle, muscle, muscle like this. Sir, how should I remember? It is so easy to remember. I will tell you the technique how to remember. So these are all 4. So what is the location of LDH3? First, let us write the location. The LDH1 was present in the heart. LDH2 is in the plasma cells, plasma enzyme, mostly especially in the WBCs. LDH3 is, we should write lungs first because lungs are the main. Lungs, pancreas, spleen. These are the places where you appreciate this LDH3. LDH4, I see both of them in muscle and liver. Are we able to understand? Are we able to understand? I hope you guys are sleeping. So guys, can you appreciate that we are able to see that they are the same enzymes, but the difference lies in the molecular subunits. Yes, this is what I want you to appreciate. Not only the definition, but also the concept. So can you now understand? In the beginning, I told you these are those, they are the enzymes. They are the physically distinct forms of enzymes, which are catalyzing the same biochemical reaction. So there is a difference in their subunits. That's why I draw these subunits. But they are the same. Means the enzyme is the same. So can you tell me which type of lactate dehydrogenase is predominant in the heart? So which type of LDH1? Very nice. So which one is predominant? Which one is predominant? Um, how to ask a question? Which one is predominant in skeletal muscle and liver? Which one is predominant in skeletal muscle and liver? So these are predominant. Very good. 4 and 5. Which one is predominant in heart? LH1 predominant. Can they be a potential MCQs, and can they also help you in diagnosing if my cell is getting damaged? If my heart is getting damaged, will the enzyme come out from the cell? Will they come in the blood? Can I see them in the laboratory? Can I check them? Yes. So easy concept. Now tell me, I tell you which enzyme predominates RBCs. Which of the following LDH predominates RBCs? It is LDH1. That's where you get confused. LDH1. So LDH1 is again in the RBCs. So guys, if you see a ratio, if I take a normal person, this is a normal person, and I take his blood sample. Simple. I take his blood sample. Okay. When I take his blood sample, it doesn't seem like a syringe. It looks like as if I am drilling something, isn't it? Yeah. So I've tried to make it a cute syringe, but it became something like no. So this syringe, when I take some blood and analyzed it, I analyzed it. I saw there was LDH2 greater than LDH1. I saw there was LDH2 greater than LDH1. But now I'm giving you an example. I'm sitting in the emergency and it's around 10 right now. For example, I'm sitting in the emergency and I got a male, 40 years old male. He comes to me with a chest pain, acute chest pain, with his fist, clenched fist on his chest, and that radiating to his neck and the left arm. Okay. And the person goes in MI. I check his blood. I see that LDH1 has gone like this. The ratio has turned like this. This concept is called flipping of ratio. So this is flipped ratio. So normally in my blood, I am appreciating LDH2 greater than LDH1, but am I patient? Myocardial infarction, what you call in common terminology is a layman language, heart attack. So we say myocardial infarction. So we have LDH1 greater than LDH2, and this is called flipped ratio. Correct? Mm-hmm. Is this clear? Okay. By the way, if you see, I told you that in the isoenzyme, I saw we have a reaction, same enzyme, same species. But what if a species is different? If species is different, if different, then we don't call it isoenzyme. We call it allo enzyme. This question was asked like this here, uh, you know, in the medical entrance test. Okay, in the licensing exam. So it was allo enzyme. So they gave you three options like this one liner. It was a one liner question, and they said what is allo enzyme, what is an isoenzyme, isn't it? So that you can get confused and you don't answer. Okay. So simple things can change your score. Simple things can no fail you. Correct. So please understand this. Mhm. How you are able to produce these isoforms? So that I will also tell you later on by the post-translational modifications or the glycosylation reaction. We go for a splicing, alternative splicing. Uh, you know, if I have a nucleotide polymorphism within the same gene. So that I will tell you later on. Okay. So next thing I want you to remember is uh, why you said it is LDH1, LDH2. See what I see is they will ask you a question. So they have asked this question many times in the entrance exam. What who is having maximum motility on electrophoresis? Who is having maximum motility on electrophoresis? Who do you think out of this LDH 1, 2, 3, 4, 5? Who is having the maximum motility? Guys, I'm asking you a question. Please reply. So guys, to understand motility concept, I don't want you to remember electrophoresis, but I want you to remember one concept. When you say about motility, we are talking about electrophoretic mobility. Electrophoretic mobility means I have an electrophoresis machine. I have a electrophoresis machine. Remember, electrophoresis machine is based on some charge, charge concept. Okay, charge concept like positive goes towards more positive and that all. I will teach you that in a separate topic. But here you have to remember that if I have a graph like this, like 1, 2, 3, 4, 5. Okay, I make this graph. I should remove this just a second. I do make it more correct. I make it like this. Okay, I have this graph. So I put LDH1 here. This is electrophoresis. LDH2, LDH3, LDH4, LDH5. And if I see the direction of mobility, the direction is through this. Direction of mobility. So can I say from this, the maximum electrophoretic mobility is shown by LDH1 because can I appreciate now? The maximum LDH motility is LDH1. Why? Because it moved the maximum. It moved the maximum. It moved the maximum. If I talk about LDH5, LDH5 is far away. It is not moving yet. No, it's moving at a very slow pace. So I say it is having least electrophoretic mobility or it has moved least. So least is LDH5 is least. Is it now clear? So you were thinking, sir, it was because RBC was moving. No, we have some concepts. It's all related to some techniques. So electrophoretic mobility is based on electrophoresis. Okay. So can I say one maximum? 5 is a bigger number but least mobility. How we remember? 1, you should understand it is least. but it is having highest because it is a topper. It is the topper. Topper means first. Fifth means least. Are you able to understand? This is how I remember. Then at the same time, I get a graph for creatinine kinase. If you check your Harper books, Harper tells us about, to my knowledge, he says creatinine kinase. Creatinine kinase. So creatinine kinase is another enzyme, CK. Creatinine kinase. So they are of three. There is isoenzyme, three isoenzymes, CK1, CK2, CK3. Yes. We can see. Yeah. But yeah, can say. So see, CK1, the subunit is brain. That is BB subunit. And it's located in brain. Location is brain. Then I see CK2. It is muscle and brain subunit. MB. So location is heart. Location is heart. Location is heart. CK3, muscle. So the location is muscle. Can we remember this? So if I tell you out of these three, which will be increased in MI, myocardial infarction, which enzyme in the blood will increase? See, we are doing clinical orientation. Very good. CK2, very good. So CK2 increases in MI. Correct? So can we do its electrophoresis? Should we do its electrophoresis? Yes, let us do the electrophoresis. So when I do its electrophoresis, what I appreciate is I see like this, like this, like this. So what is the direction? Direction is again the same. Direction of electrophoresis is this. So this is CK1, CK2, CK3. Okay. Who is now having the maximum motility? You will tell me. Maximum motility is CK1 again. Maximum motility. Least motility CK3. So when we are learning about these concepts, we don't mug up. We don't mug up. We spend some time. We are not letting you mug up. Are we able to understand? If we mug up, we forget. If we keep writing only, we forget. That is what the people get. Why we have no more selections like people studying at various places. Then we don't get selections. Why? Because we are mugging up. We are not spending time. That's what I always emphasize. Spending time on a topic is important. You think everything should happen in a gist. Everything should happen in a blink. It won't happen. It won't happen. It never happened to someone. How can it happen to you? Okay. So there is a principle in the world. You know, when you jump from the window, you fall. You don't fly. Isn't it? Unless and until you have something called a paragliding thing. So principle is something. You have to spend time. You have to study. You have to understand concepts. Then you can nicely diagnose a disease, nicely understand a disease, nicely treat a disease, rehabilitate someone. So this is the important thing. Are we able to understand? So I want you to remember what enzymes or proteins are increased. By the way, first thing, if I tell you I have something called CKMB, what What medical condition should you think? I say I have CKMB high in blood. What you should say? I have CKMB high in blood. Yes. So you should remember it can be said like CK2 or you can say CKMB. No problem. Correct? Yeah. Okay. Understood? Okay. So if I say what is the predomination of CKBB? So CKBB can be present in brain, it can be present in smooth muscle, it can be present in lung. Okay, for your sake, I want you to remember brain because you can't remember everything. So brain, smooth muscle and lungs. Brain, smooth muscle and lungs. CKMB, cardiac muscle. CKMB, cardiac muscle. CKMM, skeletal muscle. CKMM, skeletal muscle. Okay. Now, so guys, this concept that we are appreciating, the CKMB getting higher, LDH getting higher, that means, can I give it a concept? So you were actually discussing, I gave you some points from diagnostic enzymology. I gave some points from diagnostic enzymology. It was, before my medical school, it was a subject of my diagnostic enzymology. So what we do in diagnostic enzymology is we check tissue specific necrosis. We see, normally God has, or nature, it has made the human body in such a way that everything is arranged pretty much in compartments. There is compartmentalization. Everything is arranged in compartments. Liver has its own compartment, heart has its own compartment. They are not mixing their things, only the blood is flowing through them. So if this compartmentalization is impaired, disturbed, deteriorated, will actually bring some impact in the blood circulation, will actually show their appearances in the blood circulation. So when you have a tissue necrosis, you have a tissue destruction, that principle of compartmentalization is gone. The compartment is gone. I had a liver cell, for example. I had a liver cell. This is my liver cell. This liver cell contained what enzyme? ALT, for example. Yes. Does liver cell contain ALT? At least tell me this. Does it contain ALT? So now tell me, I got an injury in the liver. I got hepatitis. Hepatitis destroyed, they cause ballooning. Okay. I destroyed this. When I destroyed this, it is quite what to say, quite natural that you will say, sir, this is all enzyme, so it will leak from the cell. What is here? There is blood. So I am seeing this enzyme in blood. When I see this enzyme in blood, I am seeing the compartmentalization, the principle of compartmentalization has gone. Since you have breached the territories of the cell, that means the release of enzyme will happen into the serum, and the appearance of those tissue specific enzymes, or we can say isoenzymes in the serum, will come, and then it will help me in the diagnosing some disorders, and also let me understand the extent of damage which has happened, the extent of damage, the degree of damage which has happened to the cell. So that is the role of diagnostic enzymology while you're diagnosing an MI, or you're diagnosing any liver cirrhosis or a liver necrosis, gallbladder problem, CBD problem. I will teach you all GGT and all. I will teach you later on. Second concept to remember is what other enzymes I appreciate. What other enzymes I can appreciate in a person, or the proteins which I can see in an MI patient. So when a person comes with MI, what else I can see? So I can see, if I talk about first proteins, what proteins are increased in MI? Do you remember myoglobin? Myoglobin is raised for 2 to 6 hours. Please remember, 2 to 6 hours in the blood. And remember, please put a red mark here. It is the earliest marker. It is the earliest marker, but non-specific. Isn't it non-specific? Yes, sir. You are saying muscle. Muscle has myoglobin, but skeletal muscle also has myoglobin. Why not? Isn't it? So myoglobin, it's not that heart is only damaged. Maybe some other cell may also be damaged, but it is the earliest marker. So that's why we are saying non-specific. Now there should be something specific, like neuron network. The parenchyma, mostly neuron network, is for the CNS, the brain. I can't include a gut cell, columnar epithelium in the, in the heart. I can't include a columnar epithelium in the brain. It is all specific to those things. So that way I'm saying enzymes are also specific to something, but here it is a non-specific. I hope you have come across this term of trop ITC. Trop ITC, isn't it? Do you know trop ITC? So when I talk about trop T and I, mostly they are raised for 3 to 6 hours. So these are the proteins which are increased in MI. They are increased in MI. When I talk of enzymes I see is CKMB. CKMB remains raised for 4 to 6 hours. Then I have AST, aspartate transaminase. Okay, or you call it SGOT. So it remains raised in the blood for 6 to 8 hours. And then I have LDH1, 8 to 10 hours. Correct? So these are the enzymes which get raised in MI, in the blood circulation. Correct? Is this clear? So guys, I will be continuing this discussion tomorrow. I hope you have enjoyed my discussion. Please subscribe to my channel on YouTube also and follow me on Instagram. I will be uploading more videos like this, and also the extracts of the books are coming soon. So stay tuned, take care, and bye-bye.